This module is about screening your patient for safe, early mobility.
Welcome to the Mobility Screening and Solutions tool. Our goal across the Veterans Healthcare Administration is to safely move and mobilise all of our veterans to their highest potential and to keep our caregivers safe in the process. In order to do this, we need a common language and a standardised way to determine how much our patients can safely move by themselves and what activities they require physical assistance with. All care team members, including patients and their families, must understand the terminology and how the MSST can keep everybody safe. There are three types of movement to consider. First, passive transfer, where the patient needs to be moved without actively participating in the movement. For example, if they're sedated and they must be moved to a special diagnostics table, or if they've had multiple trauma and need to be moved onto an operating table. Secondly, during daily mobility, when the patient is participating in daily activities during hospitalisation, such as getting up for meals, going to the bathroom, performing daily hygiene, etc. In this case, the goal is to stay active and to avoid hospital deconditioning as the patient recovers from their acute illness or injury. And third, during rehabilitation, when the patients are actively trying to increase their independent mobility through a structured exercise and activity program.
In this module, you will learn how to screen your patient to determine how much they can safely and independently do by themselves and which part of the movement they need help with, regardless of whether your patient is needing help getting in and out of a wheelchair in an outpatient clinic, or on and off of an exam table, or an MRI table, or an X-ray table, or whether they need to go to the bathroom and you are the one there to give them help. You'll see on the left-hand side of this screen, there are several levels of mobility that we're going to practice screening a patient for in this module. The first question is going to be whether or not the patient can sit up at the side of the bed, with or without help. Then the next question we have is, can the patient stand up? And we're going to learn how to screen safely for that. Once we know whether they can stand and how much help they need to stand up, the next question we'll ask is, can they walk? Remember, safely and independently is what we are screening for. Then we look to what kind of equipment can help keep the patient safe and keep us safe while we help them perform that movement. We're going to practice these levels over and over again during this module, but this screen is just to introduce you to the concepts we're going to be practicing. So we've seen in the video that there are several kinds of movement that we need to consider. We're going to practice this now in several clinical scenarios, and for the purposes of this module, we're really going to focus on passive transfer and regular daily mobility. So let's practice. You are in the radiology department and a patient comes from ER on a stretcher for an MRI of their brain with tentative diagnosis of a cerebral bleed. Moving this patient onto the MRI table and back is an example of what? Take a moment. If you're in a group, discuss it with a co-worker. If you're watching this by yourself, just take a second to think through what it would be. And this is, in fact, a passive transfer. We don't want the patient to actively participate in this movement. What about this one? You are in a dental clinic and a patient comes in a wheelchair for their oral cleaning appointment. They need assistance to get from their wheelchair into the dentist's cleaning chair. This movement is an example of what? Again, just take a moment and think it through. This movement is an example of regular daily mobility. How would that patient normally get on and off the chair at home? Next, you're in the medical surgical unit. Your patient rings the bell to request assistance, getting up to go to the bathroom. This movement is an example of what? Passive transfer or regular daily mobility? This one's pretty straightforward too. This is regular daily mobility. How does the patient normally go to the bathroom? What about this one? You are on the medical surgical unit. Your patient rings the bell to request assistance repositioning in bed. Which kind of movement is this an example of? Take a couple of minutes and either discuss it with a coworker or think this through on your own. Is this passive transfer or is this regular daily mobility? The answer to this one sometimes confuses people. It is actually regular daily mobility, but very, very often we automatically, as caregivers, boost our patients passively without stopping to see, can they do it by themselves? They may be able to assist in a boost if you put a friction reducing device or a slide sheet underneath them, or even if you have a repositioning sling underneath them. If you just raise their bottom up a little bit, they may be able to walk their feet up and down in the bed. Once you've watched the early mobility video, you'll see examples of this in the module on early and progressive mobility. So if your patient is on strict bed rest, they should not be actively moving unless the medical care team has specifically given them permission to do so. A patient on strict bed rest is going to use the same technologies as somebody who's doing a passive transfer. And these include air assist technology, friction reducing devices, ceiling lifts with full body support, such as a repositioning sling or a seated sling, a floor-based lift with full body support, or using the bed features of the bed, such as sitting and tilting. So a quick knowledge check. Which of the following patients should be passively moved with full body support? Is it A, patients with suspected fractures? B, patients in a coma in the ICU? C, patients transferred onto the OR table? Or D, all answers are correct? The answer is D. All of these answers should be passive movement of our patients. So now let's talk about regular daily mobility. When the patient is admitted, the nurse or the provider will determine if they are at their baseline. This is what is normal for them. How do they move at home? And then while they are in the hospital, our job is then to restore any lost movements or maintain their level so that they don't get weaker and lose independence while they are with us in the hospital. With the mobility screen, you have two parts of it. You want to determine what the mobility goal is for your patient today. And then you want to determine how much of that goal they can do safely and independently and where they need assistance from equipment. So the goals that you have are bed level, sitting up, transferring or standing up, and then walking goals. Let's now watch a little bit more of the video clip on the MSST, and you'll actually see the mobility screen done in action.
The Mobility Screenings and Solutions tool has two main purposes. One, to establish how the patient can move right now. This is their baseline status. And two, to inform decisions about how to safely accomplish the desired activity. First, determine that the patient is available and does not have strict bed rest orders or bilateral non-weight bearing orders. Begin the mobility screen to see what the patient can do. Ask the patient to try and sit up. The patient can use the bed or the bed rail if they need to, but what you're looking for is that they can sit safely unsupported and they can shake your hand across the middle of their body once they get there. If the starting point is a chair, ask them to sit forwards and stay in that position without resting on the backrest or using their hands for support. If they cannot, then you know they need help even to sit. This patient is level 1 and requires total assistance. If the patient successfully passes step 1, you know they can sit up independently and you advance to the next step. The next question is, can they stand up safely by themselves or do they need help? Before we even ask them to stand, we need to know if they have good strength and movement in their hips, knees and ankles. Trying to stand up when both legs are weak and do not have the movement needed puts the patient at risk for a fall and also puts the caregiver at risk for an injury. Ask the patient if they can stretch out their leg and point their toes. They must be able to almost fully straighten at least one leg to pass this step. If they succeed, you know they have enough strength and movement to go on to the next step. If they are unable, they will remain at MSST level 2 and require moderate assistance. The action of raising the butt cheeks off the surface from sitting to a standing position also requires the gluteus maximus or the buttock muscles. Ask the patient to try and stand, clearing their buttocks from the bed or the chair and holding for 5 seconds. They should be able to stand safely without swaying or faltering for the full 5 seconds. If they are unable, they will remain level 3P, which means they need a powered device to help them stand up. If they succeed, even if they have to steady themselves on the bed rail or a cane or a walker, you know they are safe to stand and can progress to the next level. You now know that they can sit up and stand up independently. Next, you need to determine if they can walk safely by themselves or if they need help. Ask the patient to march in place and then step forward and back with one foot and then the other. They should be steady and have no loss of balance. If the patient is unable, they remain level 3N, which means they will need assistance to walk. If they succeed, they advance to the next level. If the patient has passed all the mobility screening steps, they have demonstrated the ability to sit up, stand up, and walk independently. They have reached level 4. If they need an assistive device, they are MSST level 4A, which means independent adaptive. If they do not need a device, then they are simply level 4. So let's just review the levels one more time. Level 1, total assistance. The patient can move in bed, but cannot safely and independently sit up and shake your hand, crossing their body without help. Level 2, moderate assistance. The patient has enough strength and balance in their body to sit up and shake your hand, but they cannot completely straighten their knee and point their toes on at least one leg. It is not safe for them to attempt standing without help. Level 3, minimal assistance. The patient has enough strength and movement to attempt standing up. 3P, these patients need powered devices to help them stand, as they are unable to stand for 5 seconds without swaying or faltering. 3N patients can stand without swaying or faltering, with or without support from a device such as a cane or a walker or a stand aid, but cannot step forward and back steadily and with good balance. They cannot walk without help. Level 4 is independent. The patient can stand up safely and independently. They can step forward and back steadily without losing balance. If an assistive device such as a walker or a cane is needed, they are level 4A. If no device is needed, they are simply level 4.
So you've seen the mobility screen now in action. You've seen what it looks like when a patient passes the tests. You've seen what it looks like when they fail a level. And remember with the mobility screen, if you are in doubt, go back to the level that protects you, the caregiver, and your patient to be able to accomplish the mobility goal. So we have to think about, how did they move before they came into hospital? Are they currently at their baseline? If not, What can we do to help them stay at their baseline? And how can we help them move safely throughout their day to get as much independence as they possibly can? Throughout the day, there are several opportunities for us to move our patients and help them with their activities of daily living. Toileting presents about 4 to 8 opportunities per day. Now, I don't know about you, some people like to remember little ditties that just make things stick in their mind. And one of these regarding toileting is, I do not normally pee in bed. Please help me to get up instead. Let's get rid of those bedpans wherever we can. Let's use the commode or the toilet, which is so much more dignified for the patient. But let's use the mobility screen to determine how to safely help them do that. Meals. Another easy thing to do is heels for meals, PO meds, and vital signs. Try to get the patient's heels on the floor at the edge of the bed or in a chair. These are opportunities throughout the day in activities you are doing anyway with your patients. And use your mobility screen to help you determine how much of that movement the patient can safely and independently do, and whether they need help. If a patient passes the first screening step, do you remember? Sitting up and shaking your hand across midline. If they can pass level 1 and they are categorized as a level 2, they do not need help to sit at the edge of the bed safely and independently. What this means is that if you're going to give vital signs at 8 a.m., you can tell your patient, at 8 o'clock, I'm going to begin to do vital signs. I want you to sit up at the edge of the bed for 10-15 minutes. So 7:45, sit up at the edge of the bed and just work on just your endurance. And I will be in at 8 o'clock to take your vital signs. Or when it's meal time, lunch will be in at 11:30. I'd like you to sit up at the edge of the bed for that. Remember, level 2, 3, and 4 can all do that without any help. Your level 1 patients may require assistance to do that. Repositioning in bed. Remember to build recovery in. Do not do it passively for your patient unless they absolutely cannot help. Use the equipment to help you. If they are a level 2, 3, or 4, this means they can sit up at the edge of the bed and they may be able to scooch their bottom up. Activities of daily living, you'll see in the notes a little further along in your VA-AES frequent documentation and activities of daily living note. This is where you document your daily mobility. Remember, your patient's goal is to get back to health. Please let them do things for themselves. So in your mobility notes, in the VA-AES shift assessment and admission assessment in acute care, there is a mobility note, a mobility section. If you click on this mobility note, you will see total assist, moderate, minimum, and independent. As you go through the steps of determining your patient's goal and their mobility level, you will then be able to determine what equipment you need to safely move them. So let's start with total assistance. You'll see in the goals here, we've got bed level activities. We've got sitting up activities, standing up, transferring, and then walking or wheelchair locomotion. For those of you who are already trained in the Johns Hopkins mobility goals, you will see in this goal section, we have included the Johns Hopkins levels. If you have not yet been trained in Johns Hopkins, then just start by thinking about bed level goals, sitting up, standing up, or walking. Some examples of bed level goals. Remember, we talked about somebody who's on strict bed rest. This means they're going to do bed level activities. Sitting up goals. This might be somebody who has lost a lot of blood and maybe very anemic. And the doctors and the care team do not want them standing and walking today. They only want them sitting up. Or it may be a patient who has COVID, whose oxygen saturation drops every time they sit. Their goal might be sitting up today. It may not be standing or walking. And then you're going to have standing goals and walking goals. So if the patient is unable to sit up independently, they do require total assistance. This means they need help sitting up, standing up, and walking. It does not mean they cannot sit up. But if the mobility goal is to sit up, stand up, or walk, then you are going to try having your patient sitting up and shaking your hand. If they cannot do it without assistance, they are level 1 total assistance. So remember, you start with the goal. The goal is determined by their medical condition and what their prior level of function was. If your patient walked at home and they come in with pneumonia or with a condition that really should not limit them from sitting, standing, or walking, then the goal may be standing or walking. The mobility screen tells you what they can safely do by themselves and how much help they need to do that safely. Let's consider a few more examples, because this can be confusing for people until you practice working through this. Your patient is waking up from sedation in the ICU. They're on a ventilator and they are extremely weak and cannot even begin to sit up by themselves. They are going to be level 1 total assistance. They may be able to sit with assistance of a seated sling, but they will require total assistance and they are going to be level 1. Let's think of another patient. Your patient had pneumonia and was walking yesterday, but they feel lousy today because they were allergic to the antibiotic they were given. They're dizzy at the edge of the bed, and you do not feel it is safe to let them sit by themselves. Their goal may be walking, but you know that they are total assistance, so you are not going to try walking them without a powered mechanical assistive device. They still require total assistance. They are still level 1, but they may be able to stand up either with a tilt bed or with a powered device, and they may be able to take some steps with a powered supportive device so that if they do get dizzy, they're not going to fall. Let's consider a third patient. Your patient has been placed on strict bed rest orders until a DVT has been ruled out. For this patient, your goal is bed level activity. You are not going to want to try and having them sit up, stand up, or walk. Their goal is bed activity. They're level 1 and require total assistance, and you're going to use one of the pieces of equipment in that first column. So let's suppose your patient has passed that first level. They are now level 2. As soon as the patient passes one test, they move automatically to the next level. And then you're trying to see, can they pass the next test to move to the next level? If the patient can sit up independently, the next question, as we saw in the video, is do they have the strength to try and stand up? The stretch and point or extend the leg step is very, very important. And this is why it's been given its whole own category. The problem has been in the past that many staff injuries occur here and many patient falls occur from their knees buckling as they try to stand. If they do have the strength, then I have the confidence that their legs are not going to buckle and I can go ahead and try standing. If they are unable to stretch and point at least one leg to almost straight, and if they're unable to bend their ankle backwards and forwards and point their toes, they remain moderate assistance level 2. It does not mean they cannot stand or cannot walk. It means they need assistance from a powered machine to safely help them do that. Next, we look at a level 3 powered, a level 3P. This is still moderate assistance. This is a patient who can sit up independently and has the strength and movement in at least one leg to try and stand. So they can stretch and point at least one leg. If they're unable to clear their buttocks and stand safely and steadily for 5 seconds, remember from the video, if they cannot do that, they will still be level 3P and require moderate assistance to stand. Many have asked, why not just combine level 2 and 3P because they're both moderate assistance? The reason is if we combined them, we have found that people skip the stretch and point step, and that leads again, remember, to a risk of the patient's knees buckling. So this is why you do have a level 2, which is moderate assistance and requires power, and a level 3P, which is moderate assistance and still requires power. The patient must be able to stretch and point and stand to pass into the 3M category. Both level 2 and level 3P require power to stand up. A level 2 lacks the strength to try and stand. A level 3 can stand with or without assistance, but they cannot hold it for 5 seconds. So now, if the patient has shown that they can stand without swaying and faltering for 5 seconds, they are in the level 3N, and we now want to determine, can they march and step to be able to walk? So the patient at a 3N can sit up unsupported, they can stretch and point, they can stand without swaying and faltering for 5 seconds. Next step is to see, can they march in place and step forward and back? If they are unable, they will remain a level 3N. They do not need power. They may need a non-powered standing. They may need a walker or a cane. And they are going to require help or assistance to walk. You'll see to the right-hand side of each of these, we've included the VA-AES note where it tells you the minimal assistance, moderate assistance, or total assistance. The next category is independent. If the patient can march in place and step forward and back safely with an assisted device, they are independent adaptive, level 4A. Now in the VA-AES, it only has total, moderate, minimal, and independent. But what you're going to put in here is they are independent with cane, crutches, or other device. If you do not feel you can allow them to walk independently, then you are going to put them back to a level 3N. If they are high fall risk, they're going to be a 3N. A level 4A patient is independent with their assistive device. This is perhaps somebody who's used an assistive device at home and brings it with them to the clinic, to the dentist's office, to an appointment, to the unit when they're admitted. They are safe with it, they are independent with it. You do not need to walk with them. But if you feel for any reason you need to be with them, then they are level 3N. And then a level 4 independent without the level A. This is somebody who does not need an assistive device. They're safe marching forward and back. There's no loss of balance. They're not at risk for falling, and you feel confident telling them you can get up to the bathroom without me. If you need to go, just get up and go. You do not need to wait for somebody to go to the bathroom. This is the full bridge document. You saw portions of this as we walked through the different mobility goals and the different levels. So the goals are across the top. If you are trained in Johns Hopkins, those numbers are here. If not, don't worry about the numbers right now. Just think about bed activities, sitting up goals, standing up and transferring, and then walking. And then what we look at is the levels. We're then going to go across and look at the equipment that will help us accomplish that. So if my goal is standing up, I know that the equipment I'm going to need is going to be in the standing up column. I'm then going to look at my mobility screen. Depending on the level they are at, it's going to tell me what equipment I'm going to need. So your patient can sit up by themselves with the help of the bed rail. Once sitting, he can balance and reach across his body to shake your hand without losing balance. He's unable to stretch either leg or bend his ankle. What is his mobility level? Hopefully, you chose moderate assistance. He is able to sit up and shake your hand. So he has passed step 1 and he's in level 2 moderate assistance category. When you try to test him to see if he can pass out of that, he does not pass that test. So he remains level 2 moderate assistance. Your patient can sit up by themselves with the help of the bed rail. Once sitting, he can balance and reach across his body to shake your hand without losing balance. He's now able to stretch and point both legs, and he can clear his buttocks from the bed. But he is unsteady while standing, even with a walker. What is his mobility level? Hopefully, you all answered 3P. Even though he can clear his buttocks, he is unsteady while standing. He still requires moderate assistance. Is it safe for this patient to stand by himself while you are not there? No, the answer is it is not safe. Is it safe for him to sit up by himself when you are not there? Yes, he can sit up by himself. He has demonstrated that he can sit safely and independently, but he cannot stand safely and independently without help. The same patient got up a few times using his walker with an ambulation harness. He's now steady standing up and taking a couple of steps as long as he has his walker. What is his mobility level? He's now a 4A. He is steady. He can take a couple of steps with his walker. He's adaptive independent. Let's try another one. Your patient rang his bell to help getting up to the bathroom. Once you raised the bed height, he could stand without help for 5 seconds without swaying or faltering. He walked to the toilet with his walker and supervision. He tries to stand from the toilet but cannot clear his buttocks. What is his mobility level? So this one's a little more confusing, isn't it? He was able to stand up from the bed without swaying or faltering. He did use a walker. So you may think that from the bed, he was a level 4A because he walked to the with his walker. But think about this. You had to raise the bed to enable him to do that. If he cannot clear his bottom from the toilet, he is level 3P. Remember, the goal of the MSST is to keep everybody safe, the patient and the caregivers. And you must do that from the lowest surface in the patient's environment that they're going to have to get up from. This happens a lot where a patient gets up from the bed with less help and then sits in the bedside chair, which is lower, and they're unable to get up from that. A lot of injuries happen to both patients and caregivers getting them up from a lower surface because we assumed they were able to stand because they did so from a high surface. So remember, when you do the mobility screen, if you have to raise the height of the bed, remember when you do the mobility screen, if you have to raise the height of the bed, you have already used power to partially stand that patient up. So they would be a 3P. They must be able to stand from the lowest height to pass that test. So again, that's why there is a difference between the bed and the toilet. So now think about your patient's mobility goal is walking. They can sit up without help, stretch and point their legs, stand up without assistance, step forward and back without loss of balance. They do not need an assistive device. What is their mobility level? This one's an easier one. They're level 4. Can your patient get up and go to the bathroom without you there? The answer is yes, unless there is something in their fall risk that makes you feel you need to be there. Again, remember, always err on the side of safety. So we need to know the daily mobility goal. We need to know what precautions the patient has. We need to do the mobility screen. And then we need to choose the appropriate safe patient handling equipment to help them achieve their goal. Let's practice a few more times with this. This is the bridge document. Remember the first step, what is the goal? Second step, what is the mobility screen tell us? And the third step, what equipment do we need? So Johnny is a 77-year-old male. He's 315 pounds. He had a severe CVA 2 days ago and is on the ventilator in the ICU. The medical team agree that Johnny's goal is sitting up until therapy comes in to evaluate him. Johnny is unable to sit up and cannot roll to either side without help. The RN has asked you as unit peer leader to help identify the appropriate SPHM equipment to help Johnny sit up. What is Johnny's mobility level? Is it 1, total assistance, 2, moderate assistance, 3, level 3P, moderate assistance, D, level 3N, minimal assistance, E, level 4A, independent assistive device, or level 4, independent no assistive device? Johnny is level 1. He cannot sit up without help. Which solution is most appropriate to help Johnny sit up today? Your options are a powered stand aid, B, an ambulation harness with a floor-based lift, C, the seated function of the bed, or D, an air assist device. The answer for Johnny is C, because remember, his medical team does not want him to stand, so any standing options are out. Option D, the air assist, does not help him achieve his mobility goal, which is to sit up today. So let's now look at Jenny. Jenny is a 75-year-old female. She's 172 pounds. She's on the med-surg unit with anemia, as she's lost a lot of blood due to a GI bleed. The medical team agree that Jenny's goal is also sitting up today. It's a different medical reason from Johnny, but her anemia is her main limiting factor. Jenny can sit up by herself using the bed rail, and she can sit without loss of balance when asked to shake your hand. There's a new CNA on the unit, and she has asked you as unit peer leader to help her decide if she needs any equipment for Jenny today. What is Jenny's mobility level? Is she total assistance like Johnny? Or did she pass level 1 and is level 2 moderate assistance? With Jenny, you're not even going to try and stand up, right? Because her mobility goal today is sitting. So already you know she's moderate assistance. If she did not have anemia, maybe that clears today and her goal tomorrow will be standing or walking. But for today, we're not going to try the standing tests because Jenny's goal is just to sit up. Her medical team do not want her standing or walking today because of her medical condition. So which solution is most appropriate to help Jenny sit up today? What do you tell the new CNA? To use a powered stand aid device? That one's out, right? Because Jenny is not to stand yet. B, no equipment needed. C, do you need the bed to help Jenny sit up? Or does Jenny need air assist transfer? Hopefully you answered B. Jenny's goal is sitting. She does not need equipment because she passed that test to do so. So remember PO meds, vital signs, meals. Jenny can sit with her heels on the floor. She can do that by herself. Jenny's goal was sitting up. But Jenny's mobility level was different, right? She was a level 2. She does not need any equipment to sit her up. Now let's think of another patient, Jeremy. Jeremy is a 63-year-old veteran who's had a below-knee amputation due to peripheral vascular disease. Jeremy's mobility goal is to stand on his unaffected side, to transfer onto the commode. So if you're picturing that bridge document, we're all the way to the stand column, stand and transfer. Jeremy can sit up in bed without difficulty. He can balance in sitting. He can stretch and point his residual leg, but the amputated limb has very little stump below the knee. He is unable to clear his buttocks from the bed to try and stand. So Jeremy's mobility level is level 3P, moderate assistance. Which solution is most appropriate to help Jeremy stand up today? A powered stand aid? No equipment? A seated sling? Or a walker? Obviously, the answer is a powered stand aid. B is out because Jeremy cannot stand by himself. He cannot clear his bottom. Option C is not appropriate because his goal is standing and transferring. So if we use a passive seated sling with him, we are not going to help him achieve his goal. And then obviously D, he's not ready for that. He needs power to stand up. Let's look at another patient. Joanna is a 75-year-old veteran who has been recovering from COVID-19. Her mobility goal today is standing and transferring. She's to go for a chest x-ray and you're about to help her get from her chair to the wheelchair. Joanna can sit forward in the chair without difficulty. She can balance in sitting. She can cross her midline. She can stretch and point both legs. She can clear her buttocks from the bed and can stand steadily without swaying or faltering. She can step forward and backwards without losing her balance, without an assistive device. What is Joanna's mobility level? Joanna's independent with no assistive device. So which solution is most appropriate to help Joanna get into her wheelchair? She doesn't need any, does she? She's able to move and transfer without assistance safely and independently. So Joanna, her goal was standing and transferring. Her level was independent. She does not need any equipment. Josie is a 54-year-old female who had a cholecystectomy yesterday for obstructive bowel disease. She has not had a great night. Her mobility goal is walking. She can sit up, and once she's up, she can balance herself and reach her hand across her body without losing her balance or holding on. She can straighten both legs and point her toes without difficulty. When you ask Josie to stand up, she can clear her buttocks from the bed, but is a little unsteady and needs to steady herself on the bed rail. When you give her a walker, she is much steadier. She can stand without swaying or faltering for 5 seconds, but you feel she's at risk for falling when she tries to walk. When she tries to march and step forward and back, she's still a little unsteady, even though she could stand for 5 seconds using the walker without swaying or faltering. What is Josie's mobility level? She's past level 1, total assistance. She's past level 2, stretching and pointing. She has good strength. She passed level 3, standing, when she had her walker. But she's not safe to walk without assistance. She's still unsteady when she tries to march and step. So Josie is mobility level 3N, minimal assistance. Which solution is most appropriate to achieve Josie's goal of walking today? Is it a walker, an active walker, with or without an ambulation sling or a fall arrest sling? Is it no equipment? Is it the chair position of the bed, or is it a walker? Josie was still unsteady walking and still at risk for falling. So it is safer to have an assistive walking device rather than just a walker for that high fall risk. So Josie's goal was walking. Her goal, she was minimal assistance, and we are going to use a walker, or she could use an ambulation harness if we're worried about her falling. You walk by a patient room in the CLC. You notice the patient is trying to get out of bed, and you see this sign below outside their door. What is the appropriate action to take? Keep walking as you're very busy and this is not your patient. Let the nurse know their patient's trying to get out of bed. Go into the patient room and let them know they should not try to get up on their own, and call the nurse while you wait with them. Or D, go in and help the patient get up to the bathroom as they obviously need to go. The answer correctly is C. Go into the patient's room, let them know they should not try to get up on their own, and call the nurse while you wait with them. You know that a level 1 patient cannot get up out of bed safely by themselves. And this is how you can use the MSST to help prevent falls. So we're going to watch one more video here, and you're going to determine what the mobility level is. Jen, we're going to get you up and get you into the car. Are you ready to go? I'm ready. Come on out the door. Let's see what you can do. Can you sit forward for me? Shake my hand. Good. What about this one? All right. You know the drill. Stretch out. You like to do both legs at the same time. All right. Can you stand for me? Can you stand up? Can you get both feet underneath you? All right. No. Okay. All right. So Jen was able to sit forward. She had been able to get up out of the bed. She was very surprised that she was not able to stand up. She stretched and pointed, no problems. We get to level 3P. She tries to stand. What happened? She was not able to. So Jan is level 3P, moderate assistance. She will require a powered stand aid to help her stand up, or a ceiling lift or a full body lift with an ambulation harness, but she will need power to safely help her get out of the chair. So let's review. Know if the movement you need to help your patient with is passive or part of their active daily mobility. Know your patient's mobility goal from the RN or the medical care team. Screen the mobility to determine how much of that movement they can do by themselves and how much they need help with. Then select the appropriate SPHM solutions to safely achieve the mobility goal for both the patient and the caregiver. Always screen your patients before getting up, even if you know how they moved the last time you helped them. Mobility levels can change if the patient is tired or if there's something changing medically with them. And then let your RN know if there's any change in mobility level. Early and safe mobility is everyone's responsibility. Remember, sit up, stretch and point, stand up, and walk. Congratulations, you have successfully completed the module on patient mobility, screening and assessment. We hope that this has helped you solidify your knowledge and feel confident screening your patients and appropriately selecting the right equipment to keep you and your patients safe. After this module, practice on each other, practice on your co-workers, get good at actually doing the screening, and put what you've just learned immediately into practice so that you will remember it. Thank you for your service to help us give back to those who have served us.